They all have a higher incidence of malignancies, so to speak, than your normal general population. So your suspicion actually goes up in that population of the country.
Thanks for that. Shannon will be presenting from Medicine 5, late effect. Go ahead.
Good morning, all. I am presenting a case on behalf of Medicine 5, late effect. This is a 40 years old farmer. Mr. R is admitted in the ward with chief complaints of alleged history of consuming 200 ml of pesticide OPC, that's chlorpyrifos, at 9 p.m. 29/11/2022. So initially he develops breathing difficulty and oral secretions along with drowsiness. So initially he was taken to a nearby hospital. Within 20 minutes, gastric lavage has been given. So following this, he has been administered atropine injection also, but the dose of atropine injection was unknown. So no history of lacrimation, urination or defecation, no such symptoms. Only 4 to 5 episodes of vomiting was there. The vomiters also contains food particles. So he was in that local hospital. On day 6, he started developing shortness of breath. So difficulty in holding up neck and getting up a supine position. So he also complained increasing the abdominal pain. So he and the epigastric region. So he was referred to CMC for further management. So past history wise, he has no co-ops, no history of any psychiatric illness, no previous history of DSI, deliberate self-harm. So personal history is an alcoholic. He consumes 150 to 300 ml per day for the last 7 years. So no history of smoking or chewing alcohol. So in examination, patient was alert, active, oriented to time, place, person, and cooperative. Vitals are stable. Blood pressure 134/70. Respiratory temperature, everything are stable. So no oral ulcers or erosions. JVP not elevated. Single breath count test at 25 seconds. Next time also 40 seconds. No pallor, icterus, clubbing, cyanosis, lymphadenopathy or pale edema. So CVS, RS, fair abdomen, CNS, everything are in normal limits. Deep tendon reflex also 1+ and symmetric at the biceps, triceps, knee and ankles. Plantar also flexor. So course in the hospital, on admission, initially he didn't have any slush symptoms. His GCS also 15/15. He was moving all the 4 limbs normally. He was ambulating. He was monitored in the ward for development of neuromuscular weakness because of the suspicion, they refer the patient to high center. So monitoring the patient for development of any neuromuscular weakness. In neck holding time was normal. Single breath count also normal initially. So on 7/12/2023, he developed increased oral secretions, bronchoria and sweating. But there was no lacrimation and diarrhea. He also developed miosis. Heart rate also was between 70 to 80 per minute. He also had a sudden drop in sensorium. His GCS dropped to E3, V3, M6. Still, he had neck holding time of 20 seconds and single breath count of 25. He was obeying commands. So what will the possible differential at this time? There is a sudden drop in GCS, but neck holding time is normal. Single breath count is normal. The patient with OPC poisoning on late. Sorry, ma'am?
Which day is it? Yeah. 7/12 was how many days after he consumed the poison?
9 days.
9 days.
9 days.
Let's see. There's a slide.
That's been used. Use the third one or clear the responses. Reset response.
The first one.
Just create.
Already 3 are created.
There are only 3 that is steps.
Actually,
The middle.
I'm okay with people putting up their hands and I can think. Anybody who wants to
The green button.
This, yeah. Plate and then don't touch it. Yeah, yeah.
Yes, ma'am. So due to sudden drop in GCS, initially.
Shannon, just put slideshow, please.
Yes.
Thanks.
Due to sudden drop in GCS, initially we did a CT brain to rule out any hemorrhage. It was normal. So we also did a ECG, rule out any ACS. ECG was showing a sinus rhythm. So no electrolyte abnormalities was there. Sodium and potassium was also in normal limits. So we did a serum acetyl cholinesterase levels. It was 121 units per liter. It was very low. So he was thought to have delayed onset cholinergic phase. So he was started on injection glycopyrrolate and injection adrenaline infusion. So after starting these drugs, there was an improvement in his cholinergic symptoms. So he improved. So initially he had improvement in his cholinergic symptoms. Okay. So after 2 days, again he developed a drop in saturation. At that time, he was not able to do single breath count and neck holding test. So at that time, we thought of he is having a delayed onset intermediate syndrome. So this time he is having a second syndrome, delayed onset intermediate syndrome, and he was shifted to ICU. He was intubated in ICU and tracheostomy was done in ICU. So he was in ICU for nearly 1 month. So the learning point is the effects of OPC poisoning. So in acute cholinergic syndrome, there will be local airway effects, alveolar fluid and bronchoria, ARDS, central nervous system defects, neuromuscular junction defects. So complication of acute cholinergic syndrome, aspiration pneumonitis, pneumonia, so immunomodulation. So intermediate effect of OPC poisoning, there will be neuromuscular junction dysfunction in intermediate syndrome. Delayed effects of OP poisoning, OP induced delayed polyneuropathy, delayed pulmonary sequelae will be there. So this is a study done in our college. So it shows delayed onset cholinergic phase usually occurs after 40 to 48 hours. Usually patient presents with cholinergic crisis. So in this case, the delayed onset cholinergic crisis occurs in 40 to 48 hours. So intermediate syndrome. In intermediate syndrome, patients develop proximal muscle weakness and cranial nerve lesions after recovery from cholinergic effects. After the patient recovers from cholinergic crisis, the patient may develop intermediate syndrome. So it's due to motor end plate degeneration due to prolonged inhibition of acetylcholinesterase. It occurs at about 24 to 48 hours after OPC induced intoxication. So it's after resolution of cholinergic excess. The patient is usually conscious. There will be proximal muscle weakness will be there. The weakness will be symmetrical and bilateral. So patient cannot raise his head from bed. Neck flexion weakness will be there. Respiratory insufficiency will be present. So among the muscles innervated by cranial nerves, extraocular muscles are the most commonly affected. There will be no sensory involvement in intermediate syndrome. Thank you.
And Shannon, what was your final diagnosis?
And delayed cholinergic crisis.
Okay, just go back to that slide that you showed, the one that was published, no, the next one. So you're saying it's but you said this was 9 days later, and the syndrome was more of a drop in sensorium rather than, I mean, initially there was no single breath count was okay.
Yes, ma'am.
All that was fine. So in that way,
it's a rare case, ma'am. It's an exception.
I meant you're looking at the timeline, and the sensorium was more of your issue. Later, the kind of the breathing difficulty and all came down. So that's one thing, because that's how we've seen the classical progression, which is why most people put dope first in terms of there's a drop in sensorium, right? Only after
drop
that
in
you
sensorium.
the only problem is the combination of having a breathing difficulty, single breath count
secretion
after that. The other thing I just wanted to ask you is Why was a CT scan done? Because
Because of drop in sensorium to result in a hemorrhage.
I know, but you will classically do it. How old was the patient?
Patient was 34 years.
Did he have any coagulopathy?
No, ma'am.
So in a way of, the only thing that happened to him was the poison that he took. So a CT scan, I'm not sure whether that would have contributed to,
Yes.
and he didn't have any focal deficits. No, it was a
No,
global
no.
loss of sensorium. So in that way, the investigations may have to be more tailored to what the original diagnosis, because he has no other risk factors. So an ICP, it would be very low on even an ACS maybe. Okay. I think those were the differentials you mentioned.
Yes, ma'am.
So I think this timeline, we classically see it followed. Sometimes we see combinations of different things. Do you think, just to the audience, what about your serum ACE levels and correlation with disease? Any doesn't correlate well. So we do know when we need to say, okay, what is patient comes unconscious, and then you want to know whether it is an OP poisoning. There's no other evidence like the smell, or there's no history or no bottle brought, then it may contribute. Otherwise, it may not correlate with the outcomes. Any other questions? We have time. So I think this graph is fairly speaks for itself. It's a useful thing, and we have seen OP in various ways. People also sometimes mix things which we don't know, so that can cause mixed effects. Thanks, Shannon.
Thank you.
I think we'll go on to the next presentation by Medicine 3. Christinus is presenting Sane and Sinew.